Hello, this is Leland Baskin. It's my pleasure today to talk to you a little bit about the basic aspects of transfusion practice. First, say I have no conflicts of interest to report. The objectives for this talk are to present information on the blood components that are available for transfusion. Discuss some of the basic definitions and principles for transfusion, cover indications for transfusion and expected outcomes, and some of the potential adverse effects and responses to manage or mitigate these reactions. Give you a little bit of background on me. I am the Vice President for Medical Operations and a pathologist at Calgary Laboratory Services, and I practice primarily chemistry, hematology, and transfusion medicine. Now, Calgary Labs is the sole provider for a city of well over 1 million and its surrounding areas. We serve at least 4,000 physicians and employ over 2,000 staff that work at 19 collection facilities and work in 5 hospital labs, as well as the central lab, which is called the Diagnostic and Scientific Center, as well as we manage staff in 10 rural laboratories. We are the referral service for a large area. We collect specimens from over 5,000 patients a day and perform right at 30 million tests in 2017. Now, this slide just shows the service delivery model for us, and that's the large central lab where I work, and then the 5 teaching hospitals surrounding it. And as you can see, with a long list of tests, the esoteric tests are performed primarily at the Diagnostic Scientific Center, as well as the main teaching hospital. Now, the blood components that are available for transfusion are listed on this slide. People think about red blood cells and platelets, but also granulocytes, plasma in various forms, and then the various plasma protein products are items that some transfusion services manage. In some cases, other departments may manage them. The diagram illustrates the composition of whole blood, which is what we call blood that is actually intact. As you can see, it's approximately half of its plasma and about half of its cellular elements, most of which are red blood cells, but also white blood cells and platelets. And plasma is primarily salt water, but it also has protein fraction that is composed mostly of immunoglobulins and also clotting factors. Now, when blood is collected, it needs to be processed fairly rapidly, and it is use of a centrifuge to separate the red blood cells from either the platelet-rich plasma or the plasma that and the platelets will be separated, and the plasma then needs to be frozen fairly rapidly in order to maintain the integrity of the clotting factors. And after it's frozen, it may be, as it's thawed, cryoprecipitate may be removed, which would leave cryopoor plasma if that's what's desired. Now let's turn to some of the basic definitions and principles of immunohematology, which is another term for blood banking or transfusion medicine. Red blood cell antigens are the glycoproteins or glycolipids that are on the surface of red cell membranes. They're usually inherited, and they define the blood groups. Antibodies are the immunoglobulins that are produced in response to exposure to an antigen that is deemed foreign by the individual. And the reaction between an antibody and an antigen that's attached to a cell membrane will lead to either cell agglutination or lysis. Now, antibodies are considered to be clinically significant if they have the potential to cause either a hemolytic transfusion reaction, and it could be either acute or delayed, or hemolytic disease of the fetus and newborn. One primary principle for a transfusion is that an antigen should never be transfused to an individual having clinically significant antibodies against it. This is similar to the underlying principle in all medicine, and then we should do no harm. Thus, in order to provide safe and effective blood components, it's important that we both identify the patient's blood group as well as screen the plasma for clinically significant antibodies before we transfuse. Now, although there are currently over 600 blood group antigens divided into 35 blood group systems, that's as of 2014, the most significant are the four major ABO groups. That's O, A, B, and AB. Antibodies to A and B antigens develop naturally in response to exposure to ubiquitous environmental antigens in the first few months of life. The second most significant groups are the two Rh, D groups. These highly immunogenic, but anti-D will only form after exposure through either transfusion or pregnancy. In the past, it was a major cause of HDN, but because we now have methods to prevent that, anti-K actually is more common. The minor clinically significant groups include the ones I show here at the bottom, but it is really worth noting that ABO incompatibility is still the major cause of immediate fatal transfusion reactions, so we have to prevent that at all costs. Now, the concept of blood groups emerged after Leonard Landois in 1875 mixed sheep red cells with dog serum. And then in 1901, Karl Landsteiner mixed human red cells and serum from different individuals to demonstrate the ABO blood group. Thus, blood bankers have some evidence to claim transfusion medicine as one of the pioneers, if not the absolute originator of the term that's popular now, personalized medicine. This table here shows the first 10 blood group systems, and it also lists what chromosome the gene is found on, as well as the year they were identified. Now, this slide contains maps of the worldwide distribution of ABO blood groups among the native populations. The information has been used extensively in anthropology to help classify groups, and it suggests complicated evolutionary history for humanity. Now, as you can see in the first map to the upper left, the group A allele is almost non-existent in Central and South Americans. The blue areas demonstrate the highest frequencies, which tend to be in specific groups in northern parts of North America and in Greenland and Northern Europe, as well as in parts of Australia. The group B allele has its highest frequency in Central Asia, and is less common among indigenous populations in Australia and in the Western Hemisphere. And then finally, Group O is most common in Central and South America, and it has a very relatively low population frequency in Central Asia. I'm not showing the distribution of Rh-D alleles, but it's very high in most of the world, with the lowest frequency being in Europeans in the low 80s. In the U.S., the overall fraction for essentially all groups is approximately 85%, being Rh-D positive. Now this table shows the distributions of ABO blood groups within the U.S. By ethnic or racial groups, even though I might add that it's not clear on how those are really defined. What I'd like to point out here is that whites have the highest proportion of Group A, while Black and Asian peoples have somewhat similar proportions of Group O to whites, but significantly less A and more B. Group O is most common among the indigenous American populations at the expense of Group B and some Group A. As you can see, in at least the Navajo tribe, B is non-existent. And this information is important to blood bankers for appropriate blood management because it determines both the available supply and the demand. Now this next table shows the approximate distribution overall in the U.S. and worldwide of the ABO groups and the compatibility for various blood components. As you can see, those with Group O, which are about 40 to 44% in the U.S., will have antibodies to both A and B antigens, whereas the AB groups, which only make up 4% in the U.S. and 6% worldwide, will have no ABO antibodies. The diagram at the bottom demonstrates the composition of the red cells in the plasma in terms of the antibodies and antigens that are present. Now, although platelets express some ABO antigens, neither platelets nor white cells will express other blood group antigens. So their compatibility assignments result primarily from the presence of red cells and plasma, respectively in their units. Now, moving on to the antibody screen, this is a tool used to detect unexpected antibodies in a patient's plasma to clinically significant minor red cell antigens on screening red cells. And about 2% of patients have antibodies. As we mentioned before, they're usually formed as a consequence of previous antigen exposure through pregnancy or transfusion. Now, if this screen is positive, antibody identification is required. Now, the diagram at the bottom illustrates the procedure of mixing the patient's plasma with screening red cells. This usually consists of a panel of about 3 different cells in order to detect these clinically significant antibodies. Now, the group and screen consists of an ABO and Rh blood group determination, and this requires about 10 minutes, and then an antibody screen that may require around 45 minutes. So in general, blood could be available in approximately an hour for most patients. Antibody identification for a positive screen may require hours to days to complete, and match compatible red cell units. So the availability of compatible units depends upon both the previous and current test results, any additional transfusion needs. For example, some patients with specific diseases might need specific types, like in sickle cell disease, or some need irradiated blood. And then finally, it depends on a clinical assessment of the urgency of the transfusion, because uncross-matched blood is always can be provided immediately for emergency situations. And that takes us to the cross-match itself, which is the final step that confirms that a red cell unit is compatible with the patient. And if the recipient's antibody screen is negative, the cross-match is used primarily just to confirm ABO compatibility, and abbreviated cross-match methods can be used, such as the immediate spin or the electronic cross-match, and these can be done in just a few minutes. Now, if the recipient's antibody screen is positive, then red cell units that are antigen negative are selected, and a full cross-match is done, and this takes at least 45 minutes. Once testing has been completed, the blood bank can then issue cross-match compatible blood. Remember, we go back to that main principle about not transfusing antigens into patients that would lead to a hemolytic reaction. It's most important to avoid ABO incompatible transfusion. So group O red cells can be issued if the patient's blood group has not been identified or verified, and group O RHD negative cells are usually reserved for women of childbearing potential, and this is going to prevent the development of the anti-RHD and the risk of HDN. If the blood group is confirmed and urgent blood is required prior to completion of the antibody screen and cross-match, then patient group-specific uncross-matched red cells can be issued. Now, uncross-matched blood can be issued almost immediately whenever it's determined that the delay in completing the cross-match is going to be detrimental to the patient. In a patient with life-threatening anemia or hemorrhage, transfusing uncross-matched cells may be safer than waiting for the compatibility testing to be completed. There's a small chance that the red cell unit could be incompatible due to minor blood group antibodies, but as we mentioned, this is very unusual, and especially if one's never been pregnant or transfused. And even if there were antibodies to the minor blood groups, hemolysis is usually mild or delayed in these cases. Now, using the frequency distribution that we presented earlier for the U.S. for ABO groups, I've just created a table here that shows if blood were chosen randomly and the patients were random, you can see that in the bold and red numbers that these would be the ones that are compatible. So about 65% of the time would you just by chance pick compatible blood. Now, this table demonstrates the value of both the group and screen and the cross-match on compatibility of transfusion. Note that what we just said was without regard to ABO groups, if we randomly chose blood, the probability of compatibility would be about almost 65%. And then doing a just grouping, we would improve the probability of compatibility by 35%. If we just had the right ABO group, compatible groups, we would have a probability of compatibility of over 99%. And once we add the RH type and a negative antibody screen, we've improved it to 99.9%. 99+%. By doing the cross match, at that point, we've only improved the probability of compatibility by another 1/100th%, or about 1 in 10,000 transfusions. So you can see that as long as we have the ABO group and a negative antibody screen, we've added very little by actually cross-matching, and so you're pretty safe in transfusing, although protocol says to go ahead and do it, because there's always a chance that some problem would arise. Now, the current sources of blood by donor status include regular volunteer donors, that's considered allogeneic blood, donation by an individual before planned procedures, that's considered autologous blood, and then designated directed donations by the patient's family, and this has been shown not to be safer, in fact, not as safe in reality than community allogeneic blood. So allogeneic blood is still the most cost-effective option by far, and then thus used most commonly. Now I want to turn to the available components with their characteristics and some general recommendations. It'll be presented in the following slides. I'm going to try to focus attention on the more important highlights for each type of component. The first I want to cover is whole blood. It's not used very often, but it was certainly the first component to be transfused. And the units of whole blood consist of around 500 milliliters of red cells with plasma and stable clotting factors and some anticoagulants. It's usually used for acute massive blood loss with hypotension, tachycardia, shortness of breath, and it requires conditions that require both increased oxygen carrying capacity and volume expansion. And the expected outcome is approximately 1 gram per deciliter of hemoglobin increase for each unit. Note, whole blood has to be ABO identical to the patient. This is important because the donor's red cells will have antigens that you hope that the patient doesn't have, and the donor's plasma will have antibodies that should not be directed towards the recipient's red cells. Now, a unit of red cells has the same number of red cells as the whole blood unit, but it is devoid of most of the plasma. It has a varying hematocrit, and it can be used for both acute or chronic anemia that requires really only the oxygen carrying capacity with its associated symptoms. And each unit should be given over a 2 to 4 hour period, but the slower rates could be used for patients who are older or those with heart disease. Sometimes diuretics need to be given at the start of the transfusion as well. Now, the expected outcome will be resolution of symptoms, but with essentially the same increase in hemoglobin as seen in whole blood. Note that sometimes saline needs to be added to lower the viscosity. And remember that chronic anemia is better tolerated than acute anemia. So in non-urgent situations, we want to transfuse red cells 1 unit at a time and only give the number of units that are really required by the patient. Now, sometimes the red cell units need to be modified, and there are 3 main modifications that can be made: leukocyte reduction, washing, and irradiation. Now, since nearly all units nowadays are leukocyte reduced, this is not really much of a modification, but they're removed at different times, and essentially 99% or more of the white blood cells are removed. The original indication was to prevent the febrile reactions, because these tend to be caused by white cell antigens and cytokines. However, now that we are leukoreducing essentially all blood, the real purpose of it now is to reduce the risk of CMV infection, and it's been shown that these are equivalent to CMV negative units, so they're, for most patients, considered to be CMV safe. Now, washing is intended to remove plasma proteins responsible for urticarial, allergic, and anaphylactic reactions, and also to remove potassium for recipients that have renal failure. The final modification is irradiation with gamma rays. This renders lymphocytes incapable of replication, and it's indicated to prevent transfusion-associated graft versus host disease in a variety of disorders. And then there are a few here. You'll see that it's not necessary to have units irradiated. I want to note that irradiation decreases the storage life of red cells to 28 days because of increased potassium linkage through the membranes. And remember that there's no radiation risk to the recipient. So here I want to just give you a general consensus of the recommendations. And this has been compiled from American Society for Anesthesia and the Ontario Regional Blood Coordinating Network. If you'll note, the single trigger is no longer recommended. Red cell transfusions are usually required at hemoglobin concentrations between 6 and 10 grams per deciliter, and especially when anemia is acute. The decision to transfuse needs to be based on the risk for complications of inadequate oxygenation, and these should occur 1 unit at a time. If we turn to platelets, which are used to control bleeding associated with either platelet deficiency or dysfunction, we'll note that they can either be collected from individual donations of whole blood, and in that case they have about 5.5 times 10 to the 10th platelets and 50 to 70 mils of plasma, and so a pool of 5 of these will have about 5 times that many in about 5 times that volume. And this turns out to be about the same number as in single donor apheresis units, which is about 3 times 10 to the 11th platelets. And they're used to control or prevent bleeding associated, like I said, with platelet deficiency, but also they're given for situations in which there's dysfunction. Now, the platelet counts tend to be the cutoffs about 10,000 or about 50,000. That's per microliter with bleeding. I've listed here a number of situations in which they're really not recommended, and in fact could do harm giving platelets in those situations. Now, they have to be stored at room temperature, and thus their storage life is only 5 days because of the risk of bacterial contamination. And after pooling occurs, and so the units have been entered, transfusion has to begin within 4 hours. As I mentioned earlier, platelets do express ABO antigens, but it's really the plasma and the red cells that are present in the platelet units that require ABO matching. Identical platelets are preferred, although sometimes other needs may outweigh this. They are also given over a 1 to 2 hour period, and the expected outcome for 1 unit of platelets would be about 5 to 10,000 per microliter. So a dose of about 5, you'd expect to have an increase of 25 to 50,000, which would be about the same thing you'd see with 1 apheresis unit. Some special considerations to note: apheresis platelets will decrease the risk of infection because it'll be one donor, usually a donor that's been tested many times and gives on a regular basis by apheresis. But pools will decrease exposure to various antigens. And HLA matching could improve responses, but only if it's documented that there are HLA antibodies that are responsible for destruction. Now, this table shows a summary of the general consensus recommendations for platelet transfusion, which we've already mentioned some of these. I want to call attention to the last one in particular, that this category includes situations such as cardiopulmonary bypass, which renders platelets dysfunctional, and the drugs such as aspirin, clopidogrel, and others will also affect their function. And then there's also congenital platelet defects that would fall in this category. So with those, platelet transfusion is accepted with higher counts as long as there's bleeding or a risk of bleeding. Let me turn to granulocytes now. They're rarely transfused since they're only required for severe infection, unresponsive to antibiotics in patients with either neutropenia or leukocyte dysfunction. An example of this would be chronic granulomatous disease. Now, the storage life for these is only 24 hours, so infectious disease testing has to be waived, and you have to come up with protocols to handle all this. Note again that because of red cell contamination, the donor red cells must be ABO compatible with recipient plasma. Now, they're transfused slowly, as you can imagine, because there's a high incidence of febrile non-hemolytic reactions. As I mentioned, these occur due to antigens on white cells, so it's hard to avoid it when you're giving white cells. I want to turn to the plasma and plasma protein products, and there's lots of these out there, and there are more all the time. Of course, we mentioned there's plasma it's been frozen and then thawed, and it's considered thawed plasma if it's after it was fresh frozen plasma, and then it had been, it can only be labeled fresh frozen plasma if it's used within 24 hours of thawing, and after that it's good for another, I believe, 4 days. Referred to as thawed plasma because some of the clotting factors, like factor 8 and 5, the labile ones, are not present, but still most of the constituents are there. Albumin, then cryoprecipitate clotting factor concentrates, and immunoglobulins, and we'll discuss these a little bit going forward. Now, I mentioned that the plasma needs to be frozen within 6 hours of collection in order to preserve the clotting factors, and it takes something close to 30 minutes to thaw it, so you've got to give yourself some time. The FFP has to be ABO compatible, and its indication then is to increase the clotting factors for documented deficiencies, and that would include an INR that's greater than 1.5, or 1.7, 1.8 in some cases, or a PTT that's greater than 1.5 times normal, with active bleeding or an impending procedure. Now, plasma ought to be infused at approximately 200 mils per hour, and so this could vary some, but up to about 2 hours per unit, like most of the other units or components we transfuse. And the expected outcome is improvements in coagulation and improvements in the lab tests that measure or approximate coagulation, but note that they may never correct fully. And the effects last about 6 hours, and this is associated with the half-life of factor 7. One thing to remember is that plasma does carry an infectious risk, whereas some of the specific clotting factors, which we're going to more and more, the concentrates can be produced with recombinant techniques that eliminate the infectious disease risk. Now, plasma is specifically not indicated for the situations here, and that is an INR less than or equal to 1.5. Like I said, you may never get these corrected completely, so we strongly recommend not providing plasma at that time. Coagulopathies in which there is no actual bleeding or impending surgery. Elective reversal of warfarin where time allows. Just because you have an elevated INR doesn't mean you have to actually reverse it if you can use vitamin K or just wait. And reversal of other anticoagulants because the plasma has no effect in reversing these. And finally, certainly not in volume expansion or nutrition support. We have other things for that, and we'll talk about those in a minute. So this table here, or slide here, summarizes again the general recommendations, consensus recommendations. Now each, by the way, for all of these that I've listed, each hospital system or medical system will have its own criteria, but they're all going to be something similar to this, and these things change with time. But this does list what they are in general, summarize them. Now, colloid solutions that consist of albumin or the plasma protein fraction, which is mostly albumin and some globulins, that's the component that people could use for volume expansion to increase both the oncotic and the overall blood pressure. And with these, just note that compatibility is not necessary, and they're pasteurized, so there's really no known disease risk with these. Turning now to the prothrombin complex concentrate, which is a fractionated product derived from plasma, and it contains the calcium-dependent, vitamin K-dependent clotting factors 2, 7, 9, 10, and protein C and S. And this is one that has been developed strictly for reversal of warfarin and in vitamin K deficient patients who have an elevated INR and also are either bleeding or are going to need imminent surgical procedures. They have been used with direct oral anticoagulants, but they're not really recommended for those, and it is contraindicated with heparin-induced thrombocytopenia. And there's several other conditions in which it's not recommended. So it should be used primarily for reversal of warfarin or in vitamin K deficiency. Now again, every institution will have different doses which depend on various indications, but it's often given in conjunction with IV vitamin K, and it can be repeated within approximately 15 minutes after infusion, and its effect lasts about 6 hours. Now, like plasma, you ought to see an improvement in the coagulation testing, but they may never fully correct. So it's primarily meant for, again, for reversing warfarin, and the advantage is that you have a concentrate, and so that you don't give nearly the volume that you would have to give if you were giving plasma. Now, this slide summarizes the pharmacologic warfarin reversal for significant bleeding, or if one's going to require urgent surgery and you want to reverse the warfarin with IV vitamin K. It could be done with oral vitamin K, but IV is a lot faster. And then if you need it in less than 6 hours, you should add the prothrombin complex in addition to IV vitamin K. Now, cryoprecipitate is a concentrated source of fibrinogen and factor VIII, along with some von Willebrand's factor, factor 13, and fibronectin. And this is all in about a volume of about 20 mils of plasma. Since it's frozen, it's going to take, again, about 30 minutes to prepare, and oftentimes it's given in pools of 10 units. Currently, its major use is to provide fibrinogen in situations in which there's hypofibrinogenemia or a dysfibrinogenemia with bleeding. It might be used in some other situations, such as bleeding with von Willebrand's disease, but only if that factor is not available, or with uremia that's unresponsive to DDAVP. It's also given sometimes as a surgical topical fibrin glue, and could be with factor 13 deficiency, but those are all much less common than with hypofibrinogenemia. Now, the dose of about 10 units will take somewhere close to half an hour to infuse, and it has to be transfused within 6 hours of thawing and 4 hours of cooling. The actual use of cryoprecipitate is decreasing because of the presence now of fibrinogen concentrates, and approximately 1 gram of that will be equal to 10 units of fibrinogen, and this provides the identical product without the volume and allows for precise dosing. So if that's what the reason for giving ordering the cryo is today, we recommend use of fibrinogen concentrate, and the trade name the one we use is called Rheostat. I think there are others out there as well. Now, coagulation factors 8 and 9 concentrates are examples of specific factors that can be currently produced by recombinant techniques, and they should be used only to replace specific deficiencies. So these are examples of products that can replace some of the other ones we've mentioned already. Their volumes are negligible, and you expect immediate hemostasis due to correcting the factor levels. I'm only going to touch on the various immunoglobulins because even though this is certainly a plasma protein product, in some situations transfusion services don't manage them, and they're divided mostly into 3 different groups. There's the intravenous and now subcutaneous immunoglobulins, or IVIG or SCIG, RH immunoglobulin, and then the specific antiviral immunoglobulins. Now, the IV immunoglobulins are provided for a number of different conditions in which there's both acquired or hereditary immunodeficiency states, as well as in immune-mediated disorders. Subcutaneous IG is starting to replace IVIG in some situations in which there's chronic use because it's not only more cost-effective because the patients can administer it themselves, but there's significantly improved quality of life for those who can handle that. Now, RHIG is commonly known as RIG or ROGAM. It specifically binds the RHD antigen on red cells when it's infused into RHD negative recipients, and this is to prevent alloimmunization and hemolytic disease of the newborn. It's also used in RHD negative individuals with immune thrombocytopenia. Finally, there are a number of different products that are directed against specific viruses, and HBIG for hepatitis B is an example of one, but there's a bunch of others, and I'm not going to get into those right now. We'll move on to transfusion administration. Now, there are a number of specific procedures required when transfusing any components, and some of them are listed here. These will be specific for each individual hospital system, but in all cases you'll have to deal with informed consent, with equipment, with the time limits for blood outside the refrigerator, and the administration time, and finally with filters that need to be applied for each in each case. I want to point out specifically the possible effects if IV solutions are mixed in while transfusing blood, and this shows with Ringer's lactate and dextrose solutions that you can have clotting, clumping, and hemolysis. And that's why we have a cardinal rule that says never mix anything except normal saline with blood products. And in fact, this has been stated at least 3 places in the Federal Register. And I show that here on this slide. Now I want to turn to some adverse effects of transfusion before we wrap up. Those are usually categorized as to either being acute or delayed, and either being immune-mediated or non-immune mediated. And I list those here, and I've highlighted the ones that are more commonly seen, even though most of those aren't very common, and the ones that are really significant: the acute, the hemolytic, febrile, non-hemolytic, allergic, transfusion-related acute lung injury or TRALI, delayed hemolytic, delayed alloimmunization, which could lead to another one at a future transfusion, the acute non-immune or the infectious contamination and circulatory overload. And it's been estimated that the risk of any adverse event is about 10%, and that would be something as mild as just causing some discomfort. Serious adverse events, though, have been estimated to be about 1 in 200, so about 0.5%, and I would think it could be even more than that. Mortality has been reported to be about 1 to 1.2 deaths per 100,000 transfusions. This table shows FDA reported transfusion fatalities in the U.S. in 2015, and you can see that TRALI accounts for the largest single number, but there's about 6 different categories here. TACO is the circulatory overload, and then there's non-ABO as well as ABO hemolytic reactions, bacterial contamination, and anaphylaxis. We want to look at specific risks of various transfusion-transmitted infections. You can see here that it's most common is bacterial contamination in platelets. And like I mentioned, platelets are stored at room temperature, therefore they're most at risk for bacterial contamination, and that's why their storage life is only 5 days. And you can see for almost everything else, it's extremely rare to have transfusion-transmitted infections nowadays. Now, on the other hand, non-infectious adverse risks are much more common. Luckily, most of these are not particularly dangerous, but we'll discuss why we're concerned about those anyway. But you can see these will make up the vast number of those, up to 10% of adverse events that might occur with transfusion. Febrile, due to red cells, due to platelets, allergic reactions, circulatory overload, all occur fairly commonly. Now, the CDC publishes this compendium of reactions on a regular basis, and it helps actually define what qualifies as a specific type of reaction. The next couple slides, I'm going to show you some of the common signs and symptoms of these, but as you'll note that many of them are not very specific. We are concerned, though, about, as I've highlighted here, the acute hemolytic, the febrile, non-hemolytic, the mild allergic, anaphylaxis, and we'll turn to the next page. And this is, we have circulatory overload, sepsis, trolley, transfusion-associated hypotension, and then delayed hemolytic reactions. Now, when one's confronted with specific peri-transfusion signs and symptoms, it's important to take specific measures that are described in the next few slides here. And in all cases, the potential gravity of the situation requires stopping the transfusion and assessing the patient, providing immediate medical attention. Now, fever is suggestive of sepsis, hemolysis, as well as a febrile non-hemolytic reaction. And although the febrile reaction is much more common, as we saw before, than the other two, it's the seriousness of those conditions that warrants this response. So we want to consider all of those, and then that's why we have to stop the transfusion and follow this protocol. Similarly, dyspnea suggests circulatory overload, trolley, and anaphylaxis. And of course, the weight of the latter two is greater than that of taco, but as we saw before, that taco causes a number of deaths in itself. So anytime there's dyspnea, we need to take immediate action. As you can see, although a number of conditions can be associated with hypotension, most are relatively benign, but we need to be able to exclude these. And if we can do that, then we could start the transfusion again. And then finally, since anaphylaxis is extremely serious, the onset of any allergic symptoms necessitates immediate treatment. But since most of the allergic reactions will be minor, response to the treatment might allow for restarting the transfusion. This brings us to the close of the talk right here. There's a lot of things we didn't cover. I'd like to cover more, but just wanted to summarize that we did discuss transfusion principles and procedures. We talked about various components and indications and some expected outcomes, and then adverse effects of transfusion and their management. And I want to leave you with a few rules of thumb from transfusion, the first being that we never transfuse an antigen for which the recipient has a clinically significant antibody. And we never mix anything other than the normal saline. into transfused blood. And then finally, we can have some expected responses to transfusions per unit would be 1 gram per deciliter for red cells, somewhere between 25 and 50,000 per microliter for platelet pools or for apheresis units. And finally, with plasma, we expect improved coagulation function and improved lab tests, but we won't necessarily completely correct the INR or the PTT with that. It's been a real pleasure to present this, and you can always reach me. My email address is on the front slide if you have any questions or comments. Thanks very much.